Hello, I'm Ben Wattenberg. The number of American couples seeking medical treatment for infertility has more than doubled in recent decades. Why the dramatic increase? What are the options open to infertile couples? Is the likelihood of successful treatment increasing? And are there ethical problems linked to some forms of infertility treatment? Joining Think Tank to discuss these and other questions are Dr. Robert Stillman, Medical Director of the Shady Fertility Centers, Elizabeth Stephen, Chair of Georgetown University's Department of Demography, Dr. Kelly Morrow, Clinical Psychologist at the Pope Paul VI Institute for the Study of Human Reproduction in Omaha, Nebraska, and Robert Blank, Professor of Political Science at the University of Canterbury in New Zealand, and author of Regulating Reproduction. The topic before the House, fertility at any cost? This week on Think Tank.
Deep in the muscle, you can inject it under your skin, belt.
Anywhere?
Yeah,
Over 1 million couples a year seek medical treatment for infertility problems in the United States. That's a sharp increase from a few decades ago. Infertility has been called the yuppie plague, but the age-specific incidence of infertility has risen only slightly. What accounts for the rapid growth in treatment? By some estimates, a woman in her late 30s is about 30% less fertile than she was in her early 20s. And today, many more couples seek to have children later, well into their 30s and even their 40s. Accordingly, many are having trouble conceiving. By no means is infertility just a woman's problem. Male fertility impairment is a factor in up to 40% of all infertility cases. There are now over 300 clinics available to patients in America. Advances in medical technology have helped meet increased demand, bringing satisfaction to thousands of couples. But serious questions remain. What about cost? What about the ethical concerns? And perhaps most important, do we really know how successful is the treatment of infertility? Ladies and gentlemen, thank you for joining us, respectively, a doctor, a demographer, a psychologist, and a political scientist. So we should really be able to solve this thing within the allotted time. Just very briefly, starting with you, Dr. Robert Stillman, how goes the revolution? We've heard of this fertility revolution or infertility revolution. Let's just go around the room once.
Well, with revolutions, there is enormous change, enormous benefit to groups of couples in this circumstance, and with it come issues and questions and complications, medical and otherwise, that need to be addressed. But the revolution goes very well for thousands of couples who can fulfill their reproductive potential, reproductive biology.
Kelly Morrow.
The revolution has helped a lot of couples and made it available for them to have their biological children. At the same time, it has raised a lot of ethical, moral, and political questions that have not been addressed sufficiently up to this point.
Okay, Elizabeth Stephen, the demographer's point of view.
Perhaps the revolution's been a little bit overblown. We tend to hear the most dramatic cases in the newspaper. There are more people seeking treatment, as you said, but for the most part, the treatment goes well and is not a part of any major news event.
Okay.
Well, I think the
Bob
technology, the changes have been dramatic and beneficial. I think there's a lack of balance, though, between assisted reproduction and trying to find the causes of infertility as well as to prevent infertility from happening. And we know some of the causes, and I think prevention is an area that's been neglected.
Okay, let's try to first look at the situation as it is on the ground today. Elizabeth Stephen, how common is infertility in America?
In the United States, as of 1995, about 10% of women aged 15 to 44 had experienced what we call impaired fecundity. Now, it's a bit of an awkward phrase, but it basically means a woman who has had difficulty or for whom it's impossible to conceive or to carry a child to term If she's married, that definition also includes her husband, that he is unable or finds it difficult to father a child, and if she's cohabiting, that her partner finds it difficult or impossible to father a child.
So the situation involves about 1 in 10 American couples.
That's right, which translates to about 6.1 million women.
Okay, is the incidence of infertility, is that getting worse?
It actually did increase in '95. Our results are based on a survey that was done also in 1982 and 1988, and it increased from about 8%.
Increased.
I'm sorry?
The rate increased?
The rate increased, and the number as well.
From what to what on the rate?
The rate increased from about 8.2% to a little over 10%. There are several reasons we think this is so. I'll just cover them very briefly. One is that infertility is in the press more, and these are self-reports. So we believe that women are being more aware of their reproductive health, and perhaps there's a little bit of stigma with infertility that may be decreasing, so people are more willing to admit they have infertility. Secondly, although the incidence of sexually transmitted diseases have decreased, we believe that
Has decreased or increased?
Decreased.
Decreased.
That there's more of a masked effect, that women are having more problems later on with this.
Why would that be?
That perhaps, particularly say chlamydia, and Dr. Stillman might address this when he speaks too, is often goes undetected. So the person doesn't even know they've had a sexually transmitted disease until they try to then have a child.
Now, it's also correct, as we said in the setup piece, that as a woman gets older, it becomes more difficult to conceive.
That's right.
And as the social patterns have changed, women seeking to have children later, that also increases the infertility incidence.
Absolutely. There's more delayed childbearing, although still the bulk of babies being born are being born to women in their 20s and early 30s, if you look in the United States.
Dr. Stillman, let me ask you this. Is the rate of success for couples seeking treatment, is that going up?
Yes. As the options increase from assisted reproductive technologies all the way to the most simple therapies are becoming more effective overall. Surgical therapies included, medication therapies included, and particularly where the data is most well known, assisted reproductive technologies such as in vitro fertilization. All of those are increasing in their success rate.
Your clinic or clinics do, as I understand it, something very unusual, because there is so much talk about, well, it doesn't work very well. You offer a money-back guarantee?
It's referred to as a shared risk program,
right.
And what it does is couples, insurance coverage for infertility is extremely limited. And for those couples who don't have insurance coverage, if they wish to participate, can have the opportunity to have, and this refers to in vitro fertilization, 3 in vitro fertilization cycles, and if they haven't had a baby at the end of those 3 cycles, they get almost all of their money back.
Is it for a woman, say, in her late 30s and early 40s, who comes into one of your clinics, says, "Doctor, I can't conceive," is it more likely today than it was 5 years ago?
Absolutely. It depends on the cause of their difficulty conceiving, but newer technologies have allowed us to treat thousands of couples who had completely irremediable infertility years ago, including in particular the 40% of male factor infertility where little was available. So a couple has a choice. They can seek childlessness or donor sperm or adoption, or higher technological procedures which can be successful for almost all men, even with the very lowest sperm counts. So that provides those who wish.
And in the last, okay, so it's better for men. In the last 5 years, has it become better for women as well?
Yes.
In what particular realms?
Well, in the overall delivery rates for these technologies.
But
newer advances.
Due to what?
Well, newer research, newer capabilities, most of it coming from Europe originally, might I add, because of the lack of funding in the United States for embryo research or for infertility research, which is a separate subject we may cover later. But research that has been done allows us to provide both safer and more effective therapies. Blastocyst culture is an example, where embryos are transferred for in vitro fertilization later on in their development. allowing us to transfer just 1 or 2 blastocysts, greatly minimizing the risk of multiple pregnancy, as well as have a higher rate of pregnancy for those 1 or 2 embryos that are transferred. So for those couples with the seeking conception and needing in vitro fertilization, the opportunity for conception and safer conception, avoiding multiple pregnancies, is an enormous benefit.
Okay, Elizabeth Stephen, that's Dr. Stillman's view from the clinic. I mean, patient by patient, reading the medical research. You are a demographer. You look at populations, plural, or the population rather than individual people. He says the success rate is going up. Can you measure that? Is that right?
If you look at the statistics that come out of the ART clinics, you can see that, and that by ART I mean the assisted reproductive technologies. That's very true. What we don't know quite as much about are the lower end of technologies. We've had a lot of multi-clinic studies, but the vast majority of women who go for treatment, which is only about 44% of all women with infertility, seek advice, diagnostic testing, and help with miscarriage. Almost all of the medical work really is at the low end. It's just maybe about 1% who end up in clinics such as Dr. Stillman's.
Again, just to pick up the same question, in the last 5 years, has there been a noticeable change and increase toward greater success as a general matter?
I don't think we know that. I think the jury is still out. Other than ART. The ART we know very well.
ART is assisted reproductive technology. That has increased.
Yes.
But those... It's increased, but it should be pointed out that most women who undergo the technique do not go home with a baby.
Okay, we're coming right now to, now we are going to talk about the problem with all of this and your court.
Well, as I said, there are many couples that go through this. Most couples that go through this will not go home with a baby. Now, that has psychological problems, I suppose, tied to that and others, but also the cost involved. The problems that I see it basically are a lack of consistency, a lack of data that we can actually compare across clinics, and I think that might get to regulation questions later.
It is a complicated thing to measure, isn't it?
It is very complicated, but different clinics, some of the more substantial clinics, such as Shady Grove, use one set of statistics that I think are more honest, but other clinics use different statistics to show success. So when you say success, it's questionable what that means.
You have another problem. I read parts of one of your papers. Basically, you're saying it's not fair. Some people have access to this, some people don't have access to it. Is that a correct characterization of?
Well, I think there are biases. I assume, again, just because something's unfair doesn't mean that we shouldn't proceed to help the people that we can help. I do think, though, there are issues in terms of, say, race. We mentioned the yuppie question before. That's changed in terms of age, but this is still basically a middle to middle upper class white benefit that's occurring. And I think there are concerns there as to a vast number of women who simply, even if we extend insurance, we still have many uninsured people in this country that would not have access.
But then isn't the answer to that to try to get such relief available to more women rather than, as I gleaned from your paper, to restrict it and use that monies for other purposes?
I think we need a balance, and I think what we don't have now is a balance. As I mentioned in my opening comment, we have, as Dr. Stillman pointed out, and it goes back to funding, about 15, 20 years ago, in 1978, funding was drastically cut, or a moratorium on certain types of funding.
Government funding. Not private funding.
Right, and that has had a tremendous impact because most of the research now has been more of the applied and as compared to basic research. And what that's meant is we haven't looked at the causes of infertility, because that's not where the money is to be made in the private sector. What we instead have seen is a proliferation of clinics from one in 1980 to over 300 today, many of which are none of which are licensed in a regulatory sense.
Right. Kelly Morrow, you have a particular problem, I guess, with some of the techniques that are in use now. Is that correct? You are coming from a particularly Catholic perspective on
Yes.
this. Is that, why don't you just very briefly try to address that?
Well, I practice psychology, and the Institute practices medically consistent with the Catholic Church teachings, which finds the assisted reproductive technologies as
this is in vitro
fertilization, gift, ZIFT,
I know.
you know, the
Right, okay.
alphabet.
There are a lot of them. Yeah, go ahead.
Right. As
Unacceptable.
as unacceptable because it separates the love and the life, the sexual intercourse act and the life. It also treats the embryos, the fetuses, the babies, as products.
Let me just ask a question, if it's appropriate. If it's not, skip it. Let's go around the room. Do you all have children?
Yeah, I have 3 children, 2 adopted, and then a surprise natural later. So yes, and they're all over 20.
I have a daughter. I went clear through IVF. Nothing worked, and we have a surprise 5-year-old.
We have 2 adopted children.
I have 2 biologic children.
You've got a pretty full.
Yeah, right.
Full,
You have the
full
whole
range,
gambit.
Do people frequently who think they can't have children and have tried everything end up having children?
It happens. There's an argument that art doesn't necessarily help people have babies. It helps them have them sooner. It's not, you know, there's a certain percentage of people who are never going to have children, no matter what they do, but that assisted reproductive technologies will shorten that gap.
Your experiences would seem to say keep trying.
Yes.
There is data,
At a certain
though,
point, you need to know the diagnosis.
No,
There is data
But yes.
on the adoption issue of is the old quote wives' tale, to use that common colloquial term, that people will conceive more after they adopt. And in fact, there's no greater statistical likelihood of conceiving after you adopt or as if you do not adopt.
I mean, we're learning so much about the psychological roots of physiological problems. One would not automatically say that's an old wives' tale. I mean, is that a woman who has a woman or a man who has adopted and feels wonderful about it because it's a remarkable human experience would be more at ease, more whatever.
It's an old wives' tale only because it doesn't seem to be more statistically true.
That's giving more credence to the power of stress on impacting fertility than actually exists. You know, like you hear a lot of couples get the advice, oh, you know, for the woman, quit work. You know, you're trying to do too much and you'll get pregnant. Go on a vacation, you know, just have a romantic vacation, that'll work.
That's fun anyway.
And
right?
I mean, those are good excuses, you know, for getting away. But although stress, psychological problems, some studies suggest really have a significant impact on infertility only about 5% of the time that can be documented. Now, the mind-body connection, of course, whenever there's stress, whenever there's depression, anxiety, which is almost inevitable when you're dealing with infertility, is going to set off a chain reaction with the hormones, let's say. And so that's one reason to address the psychological issues involved in infertility.
What are the major ethical concerns? I mean, there's this woman who had, 8 children? That's not good.
That is not good. And
What is the life expectancy of those 8 children?
To view that as it was sometimes portrayed in the press as being either common, okay, which is not, it's the only time it's ever happened, or a good thing because some of those or most of those children lived, is unfortunate. That has to be looked at as a serious consequence and side effect of therapy.
Would the same
and everything needs to be done to limit it.
Quads and triplets, same thing?
Absolutely. What it does is it raises the concerns and problems that occur with even twins, okay, but certainly triplets and quadruplets. And there are many steps being taken, but more steps need to be taken to minimize.
Was that an in vitro fertilization?
No. And that's a coin a phrase, misconception as well, in that those are not related to assisted reproduction and in vitro fertilization, because you're limiting the number of embryos you're transferring, including the blastocyst, limiting it to 2. The insurance would help, because people wouldn't be as hard-pressed to take added risks when they're not paying out of pocket. Better research would help. Through funding from the federal government, which has been recently brought yet once again from the NIH Ethics Committee. Those things will play an important role in allowing couples to limit risks, and physicians to...
Why, just to throw up a softball here, which I think I know the answer to, why is the federal government, which is pouring billions and billions of dollars into medical research, resisted going down the road of fertility research?
Most of it has been tied either to abortion politics, research on the embryo, or it's been tied to questions relating to the division between public and private.
You have some other ethical problems with this, don't you?
Well, I have some problems in terms of the line between therapy and experimentation. I think much of what we've seen over the last 20 years has basically been experimentation on women, or on couples. Under the guise of therapy. I mean, and again, I put the blame back on the lack of funding for basic research before we got into the applied research area. And I do know that it varies from clinic to clinic as to how much this is pointed out to the woman, that what in fact she is going through is not a proven therapy in any way, or something that is seen to be a treatment in a traditional sense, but rather it is experimentation to get data.
But you have,
and I think
people,
that line is not very clear.
You have couples who are, to use an overused word, I guess, are desperate to have children, and who are saying, well, I don't want to wait 10 years, because 10 years it's really going to be impossible, so why shouldn't I go to Dr. Stillman and give it a shot? You tell him what the chances of success are and potential side effects.
We try to be very specific regarding information and informed consent and risks and benefits. We try very hard to do that. Now, and I think what you're referring to, Bob, is an experimentation, not as a research project, if you will, but utilizing a therapy which we hope will be of help and effective, that there haven't been 10 years, 15 years of research behind it.
There's no data.
Right, and you generate data, if you will, by taking couples from across the country in a network and so on, and adding to that. But the idea is that with informed consent, the therapeutic trials and the therapeutic modalities that are used may not have as much basis as some other fields of medicine. And you're right, the blame for that, in large part, really needs to be the lack of funding.
My general understanding, and you all correct me if I'm wrong, is that the treatments themselves can sometimes be uncomfortable, or even painful, but are not, generally speaking, unsafe in terms of anything cataclysmic. Is that a correct?
With very, very rare exception, from what we know today, that's absolutely true.
But there are two important caveats. One is that we don't know necessarily the long-term effects of the drugs and how many times a woman goes through a particular drug.
So far, so good.
Right, but we don't know much about the children, and when there's no database that's following these children, to me that's a fascinating topic, and that's something that the federal government may want to turn to.
I want to say one thing about informed consent from a psychological point of view. And you raised it, is these couples are often very desperate. A lot of times it's the first time they haven't been able to just achieve a goal by their own efforts. They're willing to do anything to try to achieve a pregnancy, and a lot of times they have selective hearing and processing about what is being told to them in the clinics. They want to hear that, okay, there's no reason why you can't fit into this 10 or 15% of couples who walk home with a baby. They want to hear that, and it's hard for them to really process the risks.
Okay, thank you, Dr. Robert Stillman, Elizabeth Stephen, Dr. Kelly Morrow, and Robert Blank, and thank you. We encourage feedback from our viewers of Think Tank via email. It's very important to us. For Think Tank, I'm Ben Wattenberg.
We at Think Tank depend on your views to make our show better. Please send your questions and comments to New River Media, 1150 17th Street Northwest, Washington, D.C. 20036. Or email us at thinktank@pbs.org. To learn more about Think Tank, visit PBS online at www.pbs.org. And please let us know where you watch Think Tank.
This has been a production of BJW Incorporated in association with New River Media, which are solely responsible for its content.